Hi, my name is Christina Hanson, and I'm a nurse practitioner with South Denver Gastroenterology. My question is, what are the management strategies for pruritus in primary biliary cholangitis? So clearly we recognize that pruritus is a common side effect or symptom in our patients with PBC. And this can be pruritus related just to the natural history of the disease with cholestasis, or it can be a side effect, unfortunately, from the medications that we use to treat our patients with PBC. It can occur in anywhere from 20 to up to 70% of patients with PBC, and most of the time this is going to be mild to moderate pruritus, but in some patients it can be very severe, even leading to liver transplant because of its refractory nature. So let's talk about some of the management strategies. And first we're going to talk about different topical interventions and lifestyle interventions. So certainly dry skin, irritated skin can be a problem for our patients with PBC. And so using emollients, moisturizers, oatmeal extract, these are options for those patients. Certainly when the skin is irritated from heat, making sure our patients are taking cool showers instead of hot showers. They can use cold compresses, cold packs to alleviate this. And other options that they can consider are certainly trying to wear loose-fitting clothing and avoiding irritating fabrics like wool. Now let's move on to some of the pharmacologic options that our patients can use for their pruritus with PBC. So AASLD and EASL guidelines both recommend first-line therapy be a bile acid binding resin like cholestyramine or cholestyramine. And this can be very effective for our patients for their pruritus and PBC. So let's talk about first-line therapy. Pharmacologic therapy for patients with PBC. And I would say cholestyramine or cholestyramine is recommended as first-line therapy by both AASLD and EASL guidelines. And this can be very effective for our patients with PBC with their pruritus. But it's important to remember to talk to our patients about timing and dosing of this medication. So it's important to talk to our patients that when we're using cholestyramine, we want to make sure that we're taking other medications at least 2 hours before using it, or waiting for at least 4 hours after using cholestyramine or a bile acid binding resin, because certainly that medication can bind up other medications. So that's kind of the first line therapy. When we're looking at patients who are either intolerant to a bile acid binding resin or it's ineffective for their pruritus, then we're moving on to second line therapy. And one of the first second line therapies you can consider is rifampicin. Now this is a PXR agonist dosed at about 150 to 300 milligrams per day. Well, how about antihistamines? So certainly antihistamines are used to treat pruritus in the setting of PBC. It can be effective, especially used at night because of the sedating effect. And we know that pruritus can be increased for our patients with PBC at night. It has that diurnal tendency. But one of the things that's important to recognize is our patients with PBC are at higher risk of having other conditions that can cause dry eyes, dry mouth, such as Sjogren's. So it is a little bit more limiting for those patients, but again, can be used as adjunct or to augment other therapies. And then other types of pharmacologic interventions can be hydroxyzine. You can actually consider an oral opioid antagonist like naltrexone. And then interestingly enough, SSRIs, so selective serotonin reuptake inhibitors, have been studied and used in PBC for pruritus, notably sertraline, up to 75 to 100 milligram. So those are pharmacologic. What if everything else is failing? There are salvage therapies that are options. Clearly, we're not going to be doing this in our community setting. These will be at tertiary settings, possibly as a last-ditch effort before transplant, but that can include ultraviolet light therapy, nasobiliary draining, albumin dialysis, and even plasmapheresis. So again, not something that we're going to typically see, but these are options. So if we have patients who we suspect their pruritus is secondary to medications, or we want to see if we can mitigate that, but they're not responding to topical lifestyle or pharmacologic interventions, we may need to consider alterations in their medication. And this would initially be dose reduction to see if that mitigates the pruritus. If that doesn't, then we may need to take a medication holiday for a couple weeks to restart that medication at a low dose and up titrate per tolerability. And then for patients who are completely refractory, they may need to have their therapy discontinued. So those are some basic management options for pruritus in our patients with PBC. Thank you.